help me understand kind of one thing that Dan was talking about, right? He was saying that he thought that, overall a good candidate would be someone with, a very good PR or obviously a CR, right? A partial response or a complete response. But if they had metastatic sites present, would they be a good candidate for this? Or is it really only if they consolidated to, maybe the local regional lymph nodes or maybe disease in the bladder itself? What exactly does it mean? We want to really kind of tie down what exactly we're talking about here.
Yeah, excellent question. And I think the crux of your question really gets at the fact that really this is uncharted territory, right? So to your point, it's a little bit a little bit wild to think that yeah, we're going to take folks who had, pulmonary metastases or even bony metastases to the operating room for a cystectomy. But those folks did end up getting surgery in this cohort, right? So some of
Yeah,
them, a lot of them had really spectacular radiographic responses. We didn't exclude anybody. And the other thing I would, again, emphasize is this is truly just an exploratory cohort, right? I'd be very transparent. This was not done in a prospective way. This came about because oftentimes the decision about how to handle these clinical scenarios was not straightforward. Uh,
sure.
Oftentimes, honestly, the way we thought about even doing this study was we were almost, it felt like every tumor board talking about, okay, we have a patient who has been on EV pembro for 6 months, or they've gotten 6 cycles. They've had, regression of their disease, stability in their disease. Should we offer local therapy? And truthfully, no one really knew. A lot of those patients, if they were otherwise fit, did end up going to the operating room, but there wasn't, it was a lot more sort of individual clinical judgment. Okay, I think this person has pretty reasonable disease. Or the medical oncologist in some cases would tell us, hey, they've had a great response. They're good candidates for surgery, and they're having some toxicity that makes me worry about staying on the EV pembro long term, right? Maybe they're having some
I see.
immune-related side effects. Maybe they're having some peripheral neuropathy, and it'd be nice to see if we could maybe explore the possibility of a systemic therapy holiday or even cessation of systemic therapy again, which is another theme that emerged when we started looking at this data. But is again, to your point, it's not, we weren't saying, okay, you have to have 3 metastatic sites or less or whatever. It was pretty much all comers, anyone who had a good response to systemic therapy. And again, this is retrospective, so this is a lot of there's we are the first to admit there is a lot of selection bias in this cohort, right? These are the people who, they pass the eyeball test in clinic. They're sort of making it through a multidisciplinary tumor board discussion in a lot of cases. And for one reason or another, people say, okay, this is the right thing to do for this patient, or at least offer. Um, so I would say we don't have strict criteria, but everyone had, advanced disease for sure.
I see your point. But you actually said something that I kind of want to again dig down even a little deeper. Dan, maybe you can help me with this. And I think one of the points in that whole in your discussion was a vast majority of patients after surgery were able to stay off of systemic therapy, right? And that's pretty fascinating, right? Because in this world of pre-EV pembro, and there's a lot of maintenance therapy, whether it be for a certain number of times with avelumab or not. But I mean, now we're talking about, in this scenario, we don't really need to do any further systemic therapy. That's pretty great, right? I mean, what kind of comment on that? Like, what's the role of how you see that evolving in the next iteration of this study, probably?
Yeah, yeah, and that was I completely agree. I mean, I think that was huge, and like Dr. Khanna was saying, that was a really big theme that we saw emerge from this, and it became, and we were able to base that decision off the pathology a lot of times. So
Right.
we'll see in the work that we've already published, as well as some of hopefully the future work that is published on this topic from our center. There's a discordance between nodal pathology and pathology from the primary tumor, as well as there's a lot of patients that had residual non-invasive disease. So I think all those things played into the decision as to whether you continue maintenance therapy or not.
Hmm.
And I think again, I think we don't really know what the role of circulating tumor DNA is going to be in this space, but I think it's going to be important. And probably before we even know what the role of it is going to be, I think it's going to be used to make a lot of those decisions. Um,
Sure.
And because, it's another piece of information that we can use to help counsel patients, even understanding that maybe it has a better prognostic value for their overall disease. Maybe it has a good value in terms of determining treatment response and how patients will respond to future treatment. But we don't know, and it's just another piece of information that I think we can use to help counsel patients. So yeah, the medical oncologists have taken a lot of these patients off systemic therapy and have just watched them.
Yeah.
And we think that's been a big benefit for our patients. And like Dr. Khanna said, there was a big bias coming into this of, some of these were patients who the medical oncologists and the patients themselves really wanted to come off systemic therapy. And
Yeah.
this we
Right.
saw was maybe a bridge to that happening. And again, doing so in a risk adapted manner. Yeah, again, we don't know what the right thing to do is, but for this subset of patients, we think it was a benefit, and we'll see. And I think in the prospective study that's coming out, it's accruing and coming out from our center, it's going to be a lot more regimented how we do that, and the things we monitor in these patients. So I think we'll learn even more about it from some of that work.
I think I totally agree with you. And, just to spitball off one of those things, the role of ctDNA, right? And Vigor 101 really showed us, there's some role, and they used durvalumab in that study, but that was really kind of what sparked interest in ctDNA, especially in bladder cancer, right? But I can potentially see some scenario here that is after EV pembro, if they have a good PR, CR, right? And if they're ctDNA negative, they can probably remain off any therapies, right, for long term. And if they are ctDNA positive, they could potentially get, I guess, further treatment or something. I guess we're not really quite sure. Or even better, in the pre-surgical setting, the metastatic setting, if they have a true CR and they're ctDNA negative, I mean, that's almost probably a surefire way to say these patients are probably good candidates for consolidative surgery, is what
Yeah.
I'm guessing is one way to use that tool. We don't know for sure, right? But that's probably what we're going to learn in the years to come. And I'm sure your trial is going to help us answer some of those things.
Yeah, 100%. I mean, couldn't agree more with those two scenarios and the use case for them. Bearing in mind that we don't know, but I think
Yeah.
it makes a lot of sense to everyone that's how we could use that. So completely agree. And I think that's what we've thought about a lot in thinking about some of this work.